Okay, let's just talk about the structure of the write-up of the psychiatric interview. We are still talking about the psychiatric interview. Um, um, and now we are talking more about the write-up of the psychiatric interview. After we finish the interview, we write it down. So how we do that? So that's what we are talking about. And let's just, let's just go through it quickly because we are um, before Salat al-Jum'ah, inshallah. Okay, so what about the write-up of the psychiatric interview? Of course, if you know what you want to write up after the interview, that would help you a lot within the interview. You are not just in, you are, of course, you will not, you cannot actually write everything while you are interviewing the patient, but you may have some notes and head notes, but you are not taking all the you are not writing the whole history and the write up within the interview. You write it down after the interview. But when you know what you are going to write, that would help you a lot within the interview, not to forget anything important. So that's the thing. Okay. Mm-hmm. Anyways, so what's the outline of the interview write-up? First of all, we have the identification information at the first. Then we have the chief complaint. Then we have history of present illness. Then past psychiatric history, past medical history, family history, developmental and social history, mental status examination. And after that, we have differential diagnosis and list of diagnoses, assessment and information, then to the treatment plan. Again, ID, chief complaint. Then history presenting illness. Okay. Then past psychiatric, past medical, family history, developmental and social history. Then mental status examination. Then we have differential diagnosis and list of diagnoses. Then to the assessment and the formulation of the case. Then to read the treatment plan. Okay. Um, ID, we know about the ID. We are talking about ID can vary from just write the name and the age of the patient and gender of the patient to more detailed history about the patient, occupation, marital status, and so on. We tend to adopt the extended way. So the chief complaint. The chief complaint is just the patient's main concern, and it should be written within quotations, as the patient's words, like the patient is complaining of blah 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 for such time, and you don't forget the duration. That's important. Then the history presenting illness. The history presenting illness is your understanding of the patient's history. So the patient is such and such. He started to have this and this 4 months ago, and then the symptoms and this thing developed to that thing, and then what happens is this and that. Then the patient did this and going to that. That's it. Your story. You understand the story of the patient, and then you formulate it as a narrative story to talk about it in the history of present illness. And you have more than one way to write it down. Uh, we have what's called where's that? We have what's called and where's that? Okay. You can write down the. Okay, of course, if you have a highly suspicion about some diagnosis and you actually diagnose the patient with that diagnosis, or if you have some differential, you just write the history presenting illness according to that differential diagnosis. Of course, for example, if you have a patient with depression, you would just start with the history of the depressive symptoms, and you would mention the risk factors for depression within the history presenting illness accordingly. And you would also mention the pertinent negatives of that, of depression, of course, that are pertinent negatives that are related to depression, of course. If you have a differential diagnosis between, for example, depression and substance use disorder, you also tend to write the history presenting illness according to your differential diagnosis. That's okay, and that would be the perfect thing to do, actually. But there is another way to write down the history presenting illness. The first kind, it's called, I would say, it's the journalistic approach. Okay, the other approach is called an essay type of history presenting illness. The essay type of the history presenting illness tend to be something like, some books that are talking about cases, case discussions. They are not telling the story directly, because they want you to think about the case, to make your own differential diagnosis, and to reach to your own judgment. So they are just telling the story somehow as the patient's as the patient told them the story. So they are not reframing the story according to the differential diagnosis. So that's another kind, and another way to write the history presenting illness. Just write the story in general without any formulation and about without any reframing. And that would be beneficial in such situations, as I said. For example, if you want to discuss a case with your colleagues, and it's something like a puzzle, and you want them to solve that puzzle, but that would not be beneficial in the clinical setting, except if you are actually not sure about the diagnosis. You are just telling the story, and you give the listener the opportunity to make his or her own judgment about the history presenting illness. So that's how you write the history presenting illness. Other parts of the history of the writer of the psychiatry, as we said before, we have past psychiatric history, and you need to know that past psychiatric history is not just as simple as the patient is a known case of depression. That's not enough. You need to write down previous diagnoses and the duration of these diagnoses, previous admissions, previous medications, the doses of these medications, the benefit of these drugs, if the patient was compliant at those drugs or not, if there's any major side effects that happen because of these drugs, and so on. So you need to write an actual past psychiatric history, an informative history about that. And a very important part of the psychiatric history is about suicidality. Is about suicidality. And here we have a note. We have things that are repeated in the all three, I would say, timing parts of the history. The history presenting illness, which is the current problem, the past psychiatric history, previous problems, and the mental status examination, the very current problem, in the very right moment problem. We check suicidality psychosis, suicidality, and homicidality in all of these things. Always. Again, psychosis, suicidality, homicidality. We check all of these things within the all three timing aspects of the assessment. We check them in the history, in the history of present illness of this current problem. We check them within the psychiatric history, if there's any history previously about that. We check them in the very right moment of the, the time of the assessment in the mental status examination. You need not to forget that. Then we have the past medical history, about that. Family history is about family history of psychiatric problems, medical problems, these kind of things. We are not talking about, for example, family conflict, parental divorce, and these things. These are some parts of the social history. Then we have the developmental and social history. Developmental, which is about the patient himself, about the development of personal and developmental history. Then to the social history, where the patient lives, if there's any problems, social problems, economic problems and such. Then we go to the mental status examination. What we write in the mental status examination, the parts of the mental status examination are well known. We have some mnemonic to memorize them. Aseptic, A, which is appearance and behavior. A, appearance and behavior. S, speech. E, emotions, which involves mood and affect. Acept, the P refers to perception. T, thought, content and thought process. I, insight and judgment. C, cognition. General appearance and behavior. Let's start with the first part of the mental status examination. We have the general appearance and behavior. That involves level of consciousness, if the patient is sleepy, is alert or something, and the orientation if the patient is oriented to time, place, and orientation is for cognition. Forget about that. Let's just talk about appearance and behavior. If the patient is alert, the dress and grooming. If the patient is disheveled, dressing casual, dressing appropriate to his or her own gender, to his or her age, to the season, to the weather accordingly. So this is about the dress and grooming. Another thing we evaluate in general appearance and behavior is the idiosyncrasies, like unusual tattoos, unusual dress, something. If anything that need to be mentioned should be mentioned here. We are talking about the general appearance. And of course, we assess the attitude, if the patient is cooperative or not, uncooperative, not forthcoming, hostile, evasive, defensive, these kind of things. If the patient looks agitated, if he or she has some kind of psychomotor agitation or psychomotor retardation or something, if there's any abnormal movements, abnormal behavior, abnormal tics, all of these things would be written down here in the general appearance and behavior aspect section of the mental status examination. After general appearance and behavior, we have S, A, appearance and behavior, S, speech. What we evaluate in speech is the rate, volume, and quality. Rate, we are talking about slow rate, pressured rate, difficult to interpret. Okay, the rate, if the rate is slow or pressured and difficult to interrupt, and each one of these may reflect something. For example, slow rate of speech would be found in patients with depression, with schizophrenia and such. Pressured speech with mania, for example, and sometimes with anxiety. The volume of speech, if the speech is loud or soft. The quality of the speech, if it is fluent or idiosyncratic, and some of these things would be evaluated within the thought aspect, I would say. So after the S, speech, we are talking about E, emotions. That involves mood and affect. Mood, mood can be described in two ways, and you can do them both, subjectively and objectively. Subjectively, by asking the patient about his or her mood within the last 2 weeks, and what the patient is saying, you just write that word within quotations. You know, the patient is saying, I'm asking the patient about his mood. He's saying, I'm depressed. Depressed. That's the mood. You know, patient quotations, like just like that. But you can also make your objective judgment about that mood, if the patient is euphoric, dysphoric, or such. Then we move to the other part of emotion, which is affect. Affect, we comment on the range of affect. If the patient has full range of affect, the affect is the expression of emotion, I would say. The expression of emotion. Is the patient has full range of affectivity, or the patient has some restriction with that expression of emotions. Restriction, or blunted, or even flat without any expression of emotion, like poker face or something. That's why we call it flat affect. Another thing we evaluate within this aspect, we evaluate the appropriateness of that affect to the topic that we are talking about. For example, if we are talking about something sad, the patient sometimes would laugh. That's inappropriate. Or if the affect is congruent with the mood that the patient described, that's something also. Another thing we can comment on, that the stability of affect. Sometimes patients would have stable affect. That's normal. What's abnormal would be something like called labile affect. The patient would laugh, then within seconds the patient would just break down and keep crying, and then would laugh or something like that. So that's the stability of the affect. A, appearance and behavior. S, speech. E, emotions. Then P, perception. In perception, we look for any abnormality within the perception, like hallucinations, illusions, derealization, and depersonalization. And to know them just quickly, hallucinations represent perception without an actual stimuli. Illusions is the misinterpretation, perceptive misinterpretation of an actual stimuli. Derealization is some I would define it like derealization when you have a sense that you are detached from the surroundings. Depersonalization, when you have a sense that you are detached from your own body or your own emotions or your own thoughts, or all of these things. Okay. These are problems within perception. After P, we have T, thought. We usually assess thought process and thought content. Thought process, if the patient is talking is the patient talking in a goal-directed way, or if there's any other formal thought process, formal thought disorder, like the patient is talking circumstantial or tangential, or the patient is just derailing, talking about something, then moving to another idea, flight of ideas, or the patient is derailing a lot of things, mixing with each other, or the patient is just talking with word salad, what's called word salad, word from here to word from here without any. Okay, if the patient has some unusual use of language, or he or she is inventing some kind of language, this is neologism, for example. Okay, so we have what's called formal thought disorders. Another part of the thought assessment is the thought content. The thought content. in this part, we assess if there's any kind of preoccupations, worries, preoccupation about body, preoccupation about weight, about guilt, if there's any worries that that worry the patient, of course. If there's any delusions which are fixed false beliefs without any evidence, if there's any of these in the patient complains of. And within the thought content, it's important to remember that we also assess homicidality and suicidality. And as we said before, we assess homicidality and suicidality within the history of presenting illness, within psychiatric history, and within mental status examination. Okay, after thought, content, and process, we have aseptic I, insight and judgment. Insight it somehow refers to the patient's it refers to how well the patient understands that he or she has current problem, and he or she needs help or needs medication according to the case. This is insight. Judgment refers to the social judgment, if the patient can make the right call, if there's any situation, normal situation, I would say. Okay, there are types of judgments. I would not talk more about that. I see. The last thing is cognition. Cognition. In cognition, we assess more than one thing. It's not just one thing. It involves orientation. We assess if the patient is oriented to person, place, and time. What does that mean? If the patient knows persons around him, knows where he is, in what hospital, what state, what city, and so on. Is the patient oriented to time? What time is it? What day? What month? What year? And so on. We assess memory, immediate recall memory, short-term memory, and even long-term memory. Immediate recall and short-term memory, we do an assessment within the mental status examination. We ask the patient to repeat 3 words immediately and then to recall them after 5 minutes. And for the long-term memory, we just know that from the the history presenting illness. What else? We also assess attention and concentration by what's called serial sevens. We ask the patient to subtract 7 from 100, 5 times in a series. 100 minus 7, then minus another 7, another 7, another 7, another 7, and you see how the patient is dealing with that process. If the patient cannot do that, you just give them something like, what's today? Just name the days of the week, but in backward order. Just today is Friday, just what's yesterday and before that. That's it. There are some tests and assessment tools that can be used here, like Montreal Cognitive Assessment, a clock drawing test, and such. That may be beneficial here. Another thing within the cognitive assessment is the abstract reasoning, and abstract reasoning can be can be assessed within the history of presenting illness. How the patient is referring to things is just can he or she is talking about abstract things? That would be abstract reasoning. But if you are not sure about that assessment, you just can ask the patient about a proverb interpretation, and the patient should and a person with good abstract reasoning would interpret the proverb as a proverb, and patients with concrete thinking would just take the literal meaning of that proverb without an abstract interpretation of that. Okay, we read the assessment and the plan. After all of this, history presenting illness, chief complaint of course, history presenting illness, other parts of history, mental status examination, and according to that, we reach to the assessment and the plan. And we need to make an integrated assessment and treatment plan. And that plan should also follow the biopsychosocial approach. Again, when we've talked about history presenting illness and and how we understand patients, we've talked about the biopsychosocial approach to make a broad understanding, a comprehensive understanding of the patient. The same thing for the assessment and the plan. If you want to assess the patient thoroughly, more comprehensive, I would say, in a comprehensive way, in a holistic way, that would be the right thing to do. The biopsychosocial approach. Actually, for me, I have a more broader and a more thorough and holistic approach that involve the biopsychosocial approach, because in Islam we have more than that. But let's just proceed with this. I have some language limitations here to explain that, so let's just move with that. So the biopsychosocial approach is the most appropriate, at least within the Western psychiatry and psychology, I would say. So the same thing for planning, okay? But you should know that the plan, the assessment would be just like that, a brief, it should be something like a brief history about the story of the patient and your assessment about that, with a plan that is specific. It's not just for example, escitalopram 10 milligram per day for blah 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 blah. No, not like that. It should be something like, we have, for example, pharmacotherapy, which is this drug started with this dose to reach this dose. We have lab tests, this and that. We have psychotherapy, this and that. We have psychoeducation, this and that. That should, all of these things would be involved within the plan. I have an example for that. For example, as we said, sertraline 50 milligram in the morning. This is not a plan. Okay, this is not an enough plan, I would say. An assessment with a plan would be something like this. This is a 27-year-old man who presented with hallucinations and paranoid delusions that began a month ago in the context of some marijuana use and insomnia. Okay, as well as a lengthy prodrome of declining functioning and odd behavior. Okay, again, in the history of presenting illness, these things would not be like this, would not be judged like this. They would not be called hallucinations or paranoid delusion. They would be called according to the patient's history and the patient's description. You order them, you reframe the history of presenting illness, but they would not be written like this, with this kind of clinical judgment. But in the assessment, you make your clinical judgment. You just write this. And here we have the pertinent positives, the most important things within the history to make the assessment. This is a 27-year-old man, this is important, the age and the gender, who presented, what's the presentation? Hallucinations and paranoid delusions. Okay, these are the main symptoms, okay. And we assess these symptoms as hallucinations and delusions. Okay. From when these symptoms started. That began a month ago. Okay, is there any problem else? Yes, in the context of marijuana use and insomnia. Okay, there are an important comorbidities here, maybe the causes actually, as well as a lengthy prodrome of declining functioning and odd behavior. So this is the background of the patient. Our tentative assessment is schizophrenia. Here we have the assessment here. This is the diagnosis, or the more probable diagnosis here. But we will need to specifically evaluate for substance-induced psychosis. Here we have another differential diagnosis. So, what's the plan? We should write something like this: provide support and structure, ensure sleep, and begin antipsychotic medication. This is a plan. So this is a summary and this is the plan. The plan would be more extended with this kind of medication or that kind of medication. That's it. So again, summary with pertinent positives, your differential diagnosis, and your plan in details in a biopsychosocial approach. So that's it. Let's just, I'm not sure, is that recorded or not? I'm not sure. Is that being streamed live or not? I'm not sure. So let's just proceed. Here we have the conclusion. I'm just reading this from this book. Taught to students and trainees in every mental health discipline. The initial interview is fundamental to the practice of psychiatry. At the same time, the successful interview weaves together a tapestry of complex threads: differential diagnosis and common comorbidities, the link between assessment and treatment, the use of tact and timing to shift between different components of the exam, the tendency to form premature and incomplete conclusions, and the development of a therapeutic alliance. While taught to beginners, the psychiatric interview and mental status exam encapsulate much of the complexity of modern psychiatry. Here we have some clinical points. Interview tools include non-verbal communication and observations. Without a strong fund of knowledge, the interviewer is lost. Information is useful only when interpreted. Not all information is relevant. The interviewer adapts to fit the patient and the situation. The history of present illness is a creation of the interviewer. The history of present illness is longitudinal, while the mental status examination is cross-sectional. The last point here is the psychiatric interview is enriched by the active cultivation of such interpersonal characteristics as curiosity and warmth. So that's it about psychiatric interview. Okay, I think that would be beneficial to listen to it later. Okay, الحمد لله رب العالمين. هذا والله تعالى أعلم، وصلى الله وسلم على سيدنا محمد وعلى آله وصحبه أجمعين. السلام عليكم.